Okay, today we're going to be talking about Twilight versus local anesthesia. And anesthesia is essentially defined as the absence or loss of sensation, and essentially we accomplish this by medications we give that block the transmission of pain impulses from the nerve to the brain. So this allows once unbearable procedures become quite tolerable for patients and sometimes even painless. Local anesthesia, I know you guys are all really familiar with this. We use it every day, all day. Medication is applied topically or injected to a localized area, and it will anesthetize the area for a period of 1 to 4 hours. The benefit of this, there's no alteration in the patient's level of consciousness. They have no recovery. They really can get up and leave immediately after we complete the procedure, whatever it is we're doing. Conscious sedation, this is what we will be doing pending our inspection. And the term conscious sedation is used to describe a semi-conscious state that allows the patient to be comfortable but arousable during a medical procedure. Patient candidates, who are we going to select for conscious sedation? Really we want healthy people. We have to rate them according to this ASA, it's the American Society of Anesthesiologists. They created this risk stratification scale for patients undergoing anesthesia, and really it determines how safe they are to undergo a procedure that requires sedation. We here at this facility, we are only going to do 1 or 2, which means they have no systemic disease, or they have one systemic disease like high blood pressure. They take one medication and it's well controlled, or they have high cholesterol, take a Lipitor and then they're fine. Those are the only type of people we will be doing here. Otherwise, they need to go to a facility where they're under the care of an anesthetist or an anesthesiologist, because they're just higher risk patients. And then patients who are nervous or anxious about surgery, and typically patients know this about themselves. They say, you know, I'd rather just be asleep for the whole thing. I'm not a good patient, and they typically will tell you. And it's important that we convey to them that they're not going to be totally out for these procedures when we do this conscious sedation. They will be sedated. They'll be in the twilight zone, like what they do in dental offices or GI clinics. When they have their colonoscopy, they do conscious sedation. Sedation is a continuum, what we say, and we really don't know where a patient's going to fall. We can't predict that. Depending on how they're going to respond to the medications, everybody responds differently. Minimal is kind of what we do now, just Valium, PO, Vicodin, maybe an IM, Demerol, something. That's kind of where we're at now. Moderate is ultimately what we will be doing, and I'll go into a little more detail of what constitutes moderate sedation. Deep is really when you're getting into like propofol, and then general, of course, you're totally out. So moderates or conscious sedation, the patient will maintain consciousness. They will independently maintain their airway and their protective reflexes. So cough, gag, swallow. We don't want to interfere with anything like that, because then certainly that's more risky on our end and for the patient as well. The patient will respond to verbal or physical commands. So either I can say, move your arms, move your legs, or worst case scenario, give them a painful stimulus and then they'll wake up and follow commands and respond to me. They won't be anxious or afraid, and they'll experience an acceptable level of pain control. They'll have minimal change in vital signs, where really we should only have to maybe give them a little bit of supplemental oxygen or maybe IV fluids, and otherwise we shouldn't have to intervene too much with their vital signs. They'll be cooperative during the procedure. They'll have mild amnesia during the procedure. The Versed is one of the medications we'll be giving. That does have amnesic properties, so they'll remember parts of it, but they shouldn't remember the entirety of the procedure. And they'll recover to baseline promptly. We shouldn't have to recover them for 2 hours. They should be able to be discharged within 20 to 30 minutes safely home. So preparation, essentially, this is what we're already doing. They need a good physical assessment. We need a good drug history, including allergies, any previous adverse experience with sedation, including general anesthesia, like malignant hyperthermia or a family history of such, diagnostic tests, labs, and EKG. A history of substance abuse. We don't want to do anybody who is like a chronic pain patient, anybody who's on high-dose pain medications, history of physical dependence. Those really aren't good candidates because they can require high amounts of medications that we're not prepared to give to them here. They need to not have anything to eat or drink for no solid food for 6 hours prior to receiving the sedation, and no clear liquids 2 hours prior to the procedure. And they need to have transport arrangements upon discharge. So monitoring vital signs, we just monitor every 5 minutes, and there will be somebody solely assigned to monitoring that patient before, during, and after the procedure. That's their sole job, is just to monitor the patient. Recovery, before we can send them off, I mean, it's important to make sure that they're safe to be discharged home. We don't want to send a still heavily sedated patient home and have something negative happen. So this is, there's a score that's set up where we just have to make sure that they're safe to be discharged. Move all extremities, breathe in deeply and oxygenation without supplemental oxygen. Blood pressure should be within baseline plus or minus 20, and consciousness, person, place, and time, tell me where they are, name, and have a good pink color. Complications, nausea, vomiting, and then with that we would worry about aspiration. And the progression to the next state of sedation. Kind of Elaine and I were just talking about this, and we need to be prepared because, like I said, sedation is a continuum and we can never predict where a patient's going to fall, so we have to be prepared to manage a patient if they do go into the deeper level and maybe like an oral airway. It's an unpredictable kind of a gray zone. So. And discharge, vital signs need to be, stable. They need to be given verbal and written instructions on diet, activity, meds, follow-up, any post-op care. And they need to be released to a responsible adult who has to stay with them 12 to 24 hours. It's not a recommendation, it's a requirement. Just for their own safety. And that is it.